Excellent. Okay, I think we're good. All right, so I could start. All right, I'm going to start. Okay. And now I'm away from that area. So thank you for being here. Oh, I've got the advancer. Osteopathic Musculoskeletal Evaluation of the hospital patient for the NRMC House Staff. The OME, it's actually an acronym. So it was on a document I was looking at, and because I'd always learned it as the osteopathic structural exam, but the older documents and the ones published by the AOA actually say Osteopathic Musculoskeletal Evaluation. So anyhow, so that's what we're going to look at, and mostly just the diagnostic part, and then what the documentation requirements are, because we'll be looking at that. So, but as we get started, we might do an evaluation because we're thinking eventually we might do some OMT. And just for those of you that don't know what that is, that's when you take your hands as an osteopathic physician, put it on the patient with the intent of improving their health and function that have been diminished by their somatic dysfunction. Here's our definition of somatic dysfunction: impaired or altered function of the soma, the body framework. That's the skeletal, arthroidal, and myofascial parts. But then the reason we think this is important is because when this dysfunction occurs, it influences related vascular, lymphatic, and neural elements. So then what we're saying is that the musculoskeletal system can have a profound influence on our, basically the control system that works, both the musculoskeletal system as well as all the viscera. So from the point of view of the hospital patient, we're concerned with things like breathing and the heart beating. And what we're saying is that the musculoskeletal system could influence that function. So it might be worth looking at. When we go ahead and diagnose somatic dysfunction, we have 4 simple criteria to do that. We have the tissue texture abnormalities that you palpate with your hands. Is there tension in the paravertebral muscles? Is it tight or stiff there? We may notice some asymmetry of structures. Frequently, that just kind of clues us in to palpate there and see if there's motion restriction or tissue texture abnormalities. We look at motion restriction. Is something not moving that we expect to be moving? And then sometimes we look at tenderness. Again, nociception, again, increases overall metabolic demands of a body, particularly a body that, you know, is delineating more of its metabolic demands to just to breathe and circulate blood. So that small change that you get with nociception can be more significant in that patient than it would be, say, in any of us who are walking around and you tell your partner across the table, I've got some pain here, and they're like not too concerned. But in the hospital with the patient, you'd be more concerned because we know nociception can have negative influence on outcomes. Indications for doing OMT. Our main indication, if we're documenting, is somatic dysfunction. And then we would direct our treatment at what we find. But the other indication is kind of enhancing homeostatic mechanisms. And so, as we were just saying, the musculoskeletal system can be a major component of maintaining homeostasis. Our plan of intervention. So if we do an evaluation and we find something, then we might create a plan of intervention, and it might be based on what's not moving, what direction will it move. We're going to try and restore some lost motion to improve homeostasis and function. And then in the hospitalized patient, then you're thinking, okay, well, I found these 5 or 6 things, and the person is really just struggling to breathe and circulate their blood. So maybe I need to prioritize just 1 or 2 and pick the highest yield one. So our dosing in the hospital for a treatment maybe is going to be much briefer, and you may have to circle back several times throughout the day based off of what you found for that, because they may not be able to tolerate a 30-minute or a 15-minute treatment. They may just tolerate 5 to 6, 7 minutes. So you may have to be very careful in your titration. This is a statement by Dr. Seffinger, who's boarded in family practice. OMT continues to be used by osteopathic physicians as an adjunct to comprehensive medical and surgical practice. So you know, in the hospital in particular, we're just doing this as an adjunct. So many of the approaches in the hospital are used to address kind of the disease side. So if they're in with some sort of infection, you're figuring out what you're going to target and you're giving appropriate antibiotics for that. And you're doing it from that point of view. But from the host side, in terms of making the organism as healthy as possible, that's what we're looking at here. And so correcting biomechanics, particularly the rib cage and function of the lungs would be important, improving those mechanisms and including improving immune function and restoration of health. So the idea is that in the hospital, we're thinking the OMT is going to be adjunctive along with a variety of other things. And then the adjunctive nature of it's going to be such that it's going to be, hopefully it's going to be well reasoned. You're going to be thinking about, if I could do just one thing on this patient from a musculoskeletal standpoint, what would I most want to improve? And so you do that, and then they still look like they're doing okay. And you're thinking, well, if I could get away with one more, maybe what would I do, right? And you're maybe going to keep it definitely, you know, short and brief depending on your other time demands and in terms of what the patient will tolerate. We just kind of talked about that, so it's complex. Our medical and surgical management for things change over time. You guys have lectures on that all the time. Guidelines are changing, you're doing that. And then for a given patient, their overall burden of somatic dysfunction will be different. So you may have one patient with pneumonia and you check their musculoskeletal system and seems pretty supple and not too concerning to you. There's not much that really catches your attention. You'll be like, I think their musculoskeletal burden here is 2% of everything that's going on with them. And then another patient could be the exact same community-acquired pneumonia, same pathogen, and their musculoskeletal burden might be markedly higher. And you're thinking, I definitely want to treat that second patient. The first patient, maybe we'll do a little bit with if we have time, but it's not as big of a priority because you're putting that in the context of their overall management. They did come up with this kind of five element model, 5 areas of looking at it. So here you have your overall musculoskeletal system, and we're saying that the musculoskeletal system can be significant in how the individual manages environmental stresses such as trauma, infection, poor nutrition, social problems. So all those are their kind of external things. They influence the body, and then how well they manage that can be increased or diminished based on the function of the musculoskeletal system. And they have these 5 areas: posture and motion, circulation of body fluids, metabolic, immune, endocrine, neurologic, behavioral adaptations. And so in the hospital, probably if you had to pick 2, you would probably pick the respiratory, circulatory, and the neurologic if you had to pick 2. And if you were at a third, maybe biomechanical, but it's going to spill into these. And it's pretty hard to do anything to someone that you couldn't figure out how it's influencing all 5 areas. But the thought process with these 5 areas is, you know, what's your primary thing that you're shooting for? And so if you have a lot of patients, you're interested in how their respiration and their circulation is occurring. So you're going to spend time on the thoracic inlet and the rib cage and the function of the lungs. And then from the neurologic standpoint, we're thinking about basically the autonomic nervous system. So we're interested in parasympathetic and sympathetic nervous system and the influences of those on the organ systems of the patient that you're looking at, and what's kind of causing the most problems for that patient. So from that point of view, we'd probably highlight this area. And for many of the patients that are maybe on a medical service, if you hit the respiratory, circulatory, and you get the drainage spots for, say, the thoracic inlet, and you get good lung function for the diaphragm, and then from the neurologic standpoint, maybe you're doing some rib raising because of the proximity of the sympathetic chain to the anterior to the rib heads. You probably hit these 2 very well, and you can just from that little bit have a pretty marked influence. So that brings us to really what the purpose of the talk was for today, which is the osteopathic musculoskeletal exam. And it's actually a requirement for this hospital. So we're accredited by the Healthcare Facilities Accreditation Program, the HFAP, and there are accreditation requirements for acute care hospitals. And then in their document, under standard 10.01.23 for doctors of osteopathic medicine, there are requirements to do an osteopathic musculoskeletal exam as part of your H&P. And so when the hospital gets reviewed, they pull charts and they look and see, did they do these exams or did they not do these exams? And so as the house staff, you guys are doing lots of the H&Ps. And so basically, whether they meet this standard or not, you guys have a large role to play in that. And so we're going to just walk through the standards and just then at the end go through an example of what it might look like. Okay, so here we are with our standard, and it's required as part of the H&P unless contraindicated. If it is and you believe it's contraindicated, then you have to document why you didn't do it. And then the osteopathic musculoskeletal evaluation should be consistent with their medical condition and tolerance. So if they're, if they were in a bad car accident and they're in the CCU and they have several fractures and they're laying supine, there are probably certain things you won't do. You won't stand them up and you won't sit them up, but there is still an evaluation that can be done with the patient in a supine position. The times when you probably really wouldn't be able to do it would be if it's going to delay moving them on to the next part of their treatment. So you wouldn't say, well, we did the H&P and the trauma units here and they're moving them off the surgery, and you're not going to be like, oh, well, we haven't done our osteopathic musculoskeletal evaluation, don't wheel them off. That would be delaying it. But many of the situations where people think it's contraindicated, probably what's contraindicated is putting them in multiple positions. So probably whatever position you find them in, you can still do a bit of an exam to meet the requirements. So what are the goals for doing this? It's supposed to aid in your diagnosis. So as you have patients and you don't have a clear diagnosis, then you want to include your musculoskeletal evaluation and your understanding of the autonomic nervous system into that as part of your diagnostic process. And then if you do find significant musculoskeletal findings on your osteopathic exam, then you're probably going to target some of the somatic dysfunction that you found in order to help the patient heal and recover faster while they're in the hospital. And so you're going to target somatic dysfunction, some biomechanical risk factors, and the autonomic reflexes. So those are our kind of the goals for why we do the exam. And then in terms of the hospitalized patient, the documentation requirements, which is, so there are kind of two ways to get it done. One is you could have a standardized form, and we'll look at an example of one of those in a moment. And the other is you can do a narrative report as long as the narrative report meets the guidelines of what you're supposed to accomplish. So for the narrative report, there are just kind of four elements to it. One is the exam should be performed in 2 or more positions unless precluded by the patient's condition. So if they're in the CCU and they're in the supine position and they're not conscious, then you're going to do your exam with them in the supine position, and you're going to document that they're in the CCU and they're not responsive. And that's fine justification for why you did it in one position. If they're in the CCU and you sit them up in order to listen to their lungs, then when you sit them up, you run your hands along the back of their spine, and then you sit them back down as you finish the rest of their exam and the rest of your musculoskeletal exam. And now you've evaluated them in both the supine and seated positions. So if they're not doing well enough and you're just only going to auscultate them in the supine position, then you would document why you evaluated the patient in one position. If you're going to sit them up to listen to the backside of their chest cage, then when you set them up, just run your hand down that, and now you've evaluated them in both the supine and seated position. Okay. And then the exam itself, the findings that you document should be based off of your visualization, your palpating, any segmental motion or overall motion testing you do. And you're supposed to hit the major areas of the spine and pelvis. And then the document says that major findings of the extremities should be included. So it's not a thorough evaluation of the extremities. But if you have someone and they're in with pneumonia and you're evaluating the shoulder briefly just to see if that's tugging on the chest cage, that would be reasonable. If you have a patient in and maybe they have some form of an ileus or their bowels aren't functioning well, then you probably would evaluate the femoral acetabular joint for just motion. So then the report, though, so the previous one this is kind of item number 2. This isn't really anything that you can tell happened or not until you get to item number 3. The first one you can tell whether it happened or not. And then the third one is you should mention any AP and lateral curves. So you have to mention whether they're normal or not normal. So if it's an 85-year-old patient who's got 3 prior osteoporotic compression fractures, probably you would say they have increased thoracic kyphosis. I didn't observe any lateral curvature. And, if they've got pretty bad lumbar spinal stenosis, they probably have, diminished lumbar lordosis. So you would just comment on the cervical, thoracic, and lumbar spine, either increased, decreased, or normal in the AP plane, and then comment on whether you saw any lateral curvature. So that's that part. And then when you ran your hands along the paraspinals of the cervical, thoracic, and lumbar spine, then at that point, you're going to notice, is there anything that's tight or not? If there's something that's tight, you might give it a little prod and see if it's tender or not. And then the areas that are particularly stiff, you might just gently move them a little bit to see whether the tissue is just completely locked down there or stiff. And then in that case, you could say, I evaluated the cervical, thoracic, lumbar spine. There are a variety of ways to document that. You could say there was increased paravertebral muscle tension at C3 on the left, at T4 and 5 on the right, and down at T10 on the right. Something like that. Or you might, if you're very specific and are doing segmental diagnosis, you could do that. But the requirement really is that you just document something along the lines of those TART findings. So some people will say, I evaluated the cervical, thoracic, lumbar spine. I found tissue texture abnormalities and motion restriction at C1 and C2 on the left, T3 and 4 on the right, T9 on the left. Something, it doesn't have to, you're not required to give T8 was flexed, rotated right, side bent right. I mean, you can do that if that's what you find and you went that extra mile, but that's not a requirement. And okay, and then if the spine isn't examined, again, you have to document why you didn't examine that. Any questions so far in here or in our outlying regions? Okay. The standardized form is the other option. And so that one has evaluation of the curves and the positions of the exam, regional evaluation, head, neck, spine, pelvis, extremities, which TART elements. They even added severity in there as well. And then they're asking for your best assessment of major somatic and visceral correlation. So the patient is in with congestive heart failure and you found acute tissue texture abnormalities at maybe T4 and T5. And you would just, speculate that, I think that the T4-5 changes are viscerosomatic secondary to their underlying cardiovascular problem, something like that. Or they are in with pneumonia and you found some acute tissue texture abnormalities at T2 and 3 on the left, and they had a left lower lobe pneumonia. You might say, I think that those acute tissue texture abnormalities likely represent a visceral-somatic reflex. So that's the standardized form. And then again, if it's not examined, you're supposed to note why. This is what the whole form looks like. And then we'll break it in half here in a moment. Do you guys have that in a laminated card? Do you? So you can just use the card just to drive your narrative. Does anyone use a form that you turn in, or do you guys just do it in a narrative form? Mm-hmm. Narrative. You do it as a narrative? Okay. Is there anything that we've gone over so far that's different or inaccurate than what y'all believed you're okay?
I did have a question about the correlations and are those things that are required in whether we use a form or not, or those something in our documentation we have to have?
Okay. Yeah. So the question for those not on site, the question about the severity and the correlation, and so are those required elements or not? And the answer is they're not required. They're in the example form that they provided, because the example form is kind of over and beyond. But so really, in terms of minimum requirements, the request made in the narrative section is really the minimum requirements, and so they're not required for that. You can use them if you want, but so here's the top half of the example form. The spot to the right here, the optional worksheet, is just that. It's optional, so it has a name, chief complaint. Here it has the required portion listed as required, and it has anterior, posterior for spinal curves. So you would just, if the lordosis, kyphosis, and lordosis are all normal, you just, fill in the middle each spot. If they had increased kyphosis, you just fill in the increased kyphosis on that. And then for the lateral spinal curves, if you looked and didn't see anything, you just put none. Here they have functional versus mild, moderate, severe. And by functional, what they mean in this is, suppose someone had a bit of a right thoracic curvature, but when they lean to the right or side bend to the right, the curvature actually bends and it's not stiff and stuck that way. That's an example of a functional curvature versus one that's fixed. So if it is fixed, then they have mild, moderate, severe, and then they have the positions you evaluated them in. They have prone. Anyone do any prone evaluations in the hospital so far? One. It's not very common. It's challenging to do when they have an IV in. I've only done a couple when people had back pain. I just put them in a position and used the bed, and their back pain went away, so we knew it was musculoskeletal. But so we have sitting, standing, prone, supine, lateral recumbent, and then unable to examine. If you check the unable to examine again, you'd have to document, why we were unable to. Then they have the TART format tools that you used or that were present. Was there tenderness, asymmetry, motion restriction, or tissue texture? They have tissue texture change, but tissue texture abnormality is what's in the glossary. Just as an aside, that tissue texture change kind of implies that you've palpated it on a previous occasion. So, and then their severity chart, they have 0 for no somatic dysfunction, 1 for just mild, close to background dysfunction, 2 for moderate, and it's correlating maybe with some symptoms, and then 3 for some of the most significant stuff, either the key dysfunction or one of several key dysfunctions. The optional worksheet is up here on the right, and this sheet, it has for those of you that would do a quick zinc pattern screen where you're just looking at the respiratory, kind of the fascial diaphragm rotational preference at the OA, thoracic inlet, abdominal diaphragm, and pelvis. It has ways to code for that rotation. It has the mark in the middle here for celiac, superior mesenteric, inferior mesenteric ganglia. Of note also that the renal takeoff is about at that same location as the superior mesenteric. So if find that, I mean, that's going to be in that same area. Some people will use this optional one, and if they found a Chapman's reflex, they might just circle it and draw a little line out to the side and say CR next to it for Chapman's reflex. And then the other parts are just the way they have the cervical spine organized. So on the top at the back here, it says C0 or C1 and 2. Basically, you're looking at the OA to C2. And so that would be your autonomic nervous system correlation, say, with the vagus nerve. So people are interested in evaluating that area for possible influence on the vagus nerve. Then as you get through it, then it has C3 to 7. So that area includes C3 to 5. So if you're interested in diaphragm function and there's some dysfunction there, then you're going to want to note that. And then as we get into the thoracic area, T1 to 4, 5 to 9, 10 to 11, T12 to L2. So these kind of large autonomic nervous system patterns for that. Then they have something down at the SI joints. So if you wanted to meet the guidelines and you just palpated down the back side, as long as you kind of hook the PSIS and palpate into that SI tissue, then you can comment on the SI joints, and that'll show that you've included the pelvis. So any questions on the top half of the form? Good. All right, and then the bottom half is a kind of a more detailed way of filling in the severity. So they give you the 0 to 3 option for the head, neck, T1 to 4, 5 to 9, 10 to 12, lumbar, pelvis, sacrum, innominate, and the extremities, rib cage, abdomen. And then the way they have it here is there's a blank spot. So if you're the one that's like, well, I don't know why they didn't include my favorite diagnosis, then you just write your favorite diagnosis in there. So T4, flex, rotated, side bent right. You could write that in there if you went to that much trouble. But, you know, if you just said that there are acute tissue texture abnormality changes or tissue texture abnormalities found at T3 on the right and left, or you could just say T3, and that probably by default means it's both sides, right? So that would be sufficient enough. So okay, and then just lastly along that lines, there have been occasions where we've had a faculty member who documented in a note that they or you know that they saw someone and they billed for treating the thoracic spine and lumbar spine, and someone was asked after the fact to finish the note that they found wasn't finished. So if I knew that someone diagnosed the somatic dysfunction in the thoracic region, then I had to create a note. I would just say tissue texture abnormality, motion restriction, and or asymmetry and tenderness was found in the thoracic region today. And that meets the billing and coding requirements for documenting somatic dysfunction, because remember that the TART, the T-A-R-T, is that's the diagnostic criteria for somatic dysfunction in a body region. The specifics of saying something's rotated this way and side bent that way is just a specific of either asymmetry or motion restriction findings, right? That's a level of detail that's nice to have if you're going to be looking at the note later and wondering whether it's different, but it's not a level of detail that's needed to justify the fact that you did evaluate it and you did find something, right? Oh, and then they have the correlation. So if you found something and you thought it was correlated with the fact that they were hit by a car or just had their right hip replaced or they're having an MI or whatever the reason, then there are these categories for what you think the major correlations were on your patient. So that's the documentation part. Any questions before I just do a quick demo? We can do several quick demos to see different ways that you might get it done rather quickly without it taking up a lot of your time while you're seeing your patient. So any questions before we move to that part? Okay, I will need a volunteer. So I made eye contact with you and you offered me a cookie, so come on up. Anyone that's willing to sacrifice themselves for science is always appreciated. So, yeah, which you want to? Well, let's do supine. So, either maybe head at that end. Yeah, I think so, because that way we can.
You want the lights down now so they can see what we're at.
Yes, is that the right answer? Can you guys? Yeah. Okay. Oh, that's right. Eric, if anyone's eyes closed, they're the next volunteer. Okay. Unless they're yours, then just walk up here. Okay. So, hello, Eric Snider.
Hi, I'm
Mazur. All right. Well, thank you for being in our hospital today and choosing Northeast Regional Medical Center. All right. So let's say Mazur's in and he's got some sort of cardiovascular problem and he's not able to sit up. In fact, maybe he's intubated or not intubated. My exam could look this simple. Mazur, I'm just going to check the back of your neck and through the back of your spine just to see if there are any musculoskeletal changes that we might be able to address as part of your stay here to help you feel a little better. All right, so I'm just going to reach under and I'm just feeling the muscles in the back of your neck up top here. And there's a little bit of tension here on the left at C2. And I reach down and I'm hitting at C7. There's a little something on the left as well. And then I'm just going to reach under your spine. And I'm just going to lift up on your upper part of your spine. And there's some tension here at T3 here on the left. And then I'm going to palpate the paraspinal muscles on either side. And there's a little more tension on the left. And then I'm going to come in. And now I'm down here from about T6 to probably T12. And I lift up on the spine. There's a little stiff spot. So I'm going to check the paraspinals on either side. A little something right there. Is that tender? Not bad? Okay, so a little bit of change at T8, but not tender on the right. And then we'll lift under both sides here again. I'm just on the spinous processes, just lifting up. And then anything that's a little stiff, then I'm palpating the paraspinals on either side. And again, here at L1 on the right, a little bit of change there. And then I'm just going to check your SI joint here on the right. And I can check the SI joint on the other side. And I could even just check the pelvis this way. And that's a pretty quick evaluation for someone where I'm documenting that, you know, they're supine. And for whatever reason, I could only do the evaluation in one position. And I just kind of reached under. So I did the paraspinals from the front and then just reached under, lifted up on the spine. And anywhere I found something a little stiff, then I checked the paraspinals on either side. That's a pretty quick way to do it. There's nothing wrong with doing the whole thing from one side and then going to the other side. So you could do something like that. I'm just going to check your spine on both sides here. So I'm going to reach under and check your neck, but I'll probably get the whole neck. And then I'm going to come down one side on the paraspinal area. And I'm probably from T1 to 6. And then I'm going to come back a little bit and lift up on the ribs. So now I'm doing paraspinal and ribs. And then I'll be in the middle part of the spine here. And I'll reach all the way under to the paraspinals on the right. And then come back to the ribs and lift them. And then I can reach under again, paraspinal in the lumbar area. Check that. Then I could do a little compression test just to check the pelvis. And then come around to the other side. And again, just check under the paraspinals in the neck, down into the thoracic area. So I'm in the upper thoracic, so I'm in the paraspinal muscles. Then I pull out laterally and I lift the ribs just to see what's going on. That tender there? Yeah, so he's got a nice rib there at about 3 on the left that's stiff and tender. And then I'm going to come out. Now I'm in the mid part again, paraspinals. Pull out to the ribs, and I'm in the mid part again, paraspinals. There's no ribs down in the lumbar spine. At least there weren't when I went to school. And then checking the pelvis. So that's a pretty quick way of doing it on both sides. If you want to do it supine and include the just the diaphragm. So you could do the head this way. So you palpate the cervical spine, palpate the tissue there, and just very gently rotate the head to get a preference for rotation. So I'm doing this without standing at the head of the table in case you don't want the additional time of sliding the bed out. You could do the thoracic inlet rotation just from this position, and you can come down and do the abdominal diaphragm rotation from this position anteriorly. You can even check into the epigastric area and then check along the celiac, superior mesenteric, and inferior mesenteric ganglia. All right, tender in there, yep, and there, less. So a little bit of epigastric tenderness. If you found that, then that might, I usually wouldn't do a full Chapman's reflex screen, but if I found something that piqued my interest, then I might follow that up and just check, you know, do you have this Chapman's reflex there for the stomach? So anyhow, that's good. It lets us know that he's working hard as an intern, and so, or internal medicine resident, sorry. And so that would be just, you know, a very brief with them in one position. And then let's say though that I come in and I check him and he's able to sit up. So maybe we talk some of the physical exams being done in this position, and then if we sit him up, so he sits up a little bit in his bed and we're auscultating, stethoscope on the skin, obviously, back here on both sides. Then from here, I may check the paraspinal muscles. I may take my hands and just, oops, maybe let's switch end for end here so they can see where I am.
Sure.
Yep, thanks. He wouldn't be able to do that without getting the IV wrapped around him. So, but anyhow, from this position, I may just, after I've auscultated back and forth, right, I may then go ahead and just quickly, I can run one hand down the whole thing, and that you get a lot of information if you do that every time you do one. You can run one hand down, and every time you feel something, just stop and check it. So he's got some changes there, and then there's a little something right there. I can check that. Not so bad in this position down there. So you could do your evaluation that way pretty quickly. All right, thank you. Any questions on that, or Eric, anything else? We're good. That's all I have for today. So if there are no other questions at the outlying site, we'll just check and see, and then we'll be done. We're good. All right, thank you for your attention.